Welcome to the MRCS Bites session on autonomic nervous system and spine anatomy and pathology, OSCE Station 1. Today, we'll dive into this topic and explore the common questions tested during the MRCS Part B exam. For more information and full course, please visit mrcsbites.com. Question 1. Name the ascending tracts in the spinal cord. The ascending tracts in the spinal cord are responsible for transmitting sensory information from the body to the brain. Here are the major ones. Dorsal columns carry fine touch, two-point discrimination, conscious proprioception, and vibration sensations. They include fasciculus cuneatus, carries sensory information from the upper body. Fasciculus gracilis, carries sensory information from the lower body. Spinothalamic tract. This tract carries pain, temperature, and crude touch sensations to the thalamus. Spinocerebellar tracts include dorsal spinocerebellar tract. Transmits proprioceptive information to the cerebellum from the lower body. Ventral spinocerebellar tract. Transmits proprioceptive information from the lower body and some upper body to the cerebellum. Each of these tracts plays a crucial role in processing and relaying sensory information to the appropriate areas of the brain for interpretation. Question 2. Name the descending tracts in the spinal cord. The descending tracts in the spinal cord are pathways that carry motor signals from the brain to the muscles and glands. The main descending tracts include corticospinal tracts, also known as pyramidal tracts. They are lateral corticospinal tract. Primarily controls voluntary movements, especially fine movements of the limbs. Ventral corticospinal tract. Mainly controls axial muscles, such as those in the neck and trunk. Extrapyramidal tracts include rubrospinal tract, involved in the control of motor functions, particularly flexor muscles of the upper limbs. Tectospinal tract. Coordinates head and eye movements in response to visual stimuli. Vestibulospinal tract. Maintains posture and balance by controlling the muscles of the neck, trunk, and limbs in response to head movements. Reticulospinal tract. Influences voluntary movements and muscle tone, and mediates autonomic functions such as respiratory rhythms. Question 3. What functions are carried out by the spinothalamic tracts? The spinothalamic tracts are crucial for transmitting sensory information from the body to the brain. They carry different types of sensory modalities. Lateral spinothalamic tract transmits information about pain sensations, including sharp and acute pain. It also conveys information about temperature changes, including both hot and cold sensations. Anterior spinothalamic tract carries sensations related to rough or general touch, which is less detailed than the fine touch transmitted by the dorsal columns. Question 4. What functions are carried out by the corticobulbar tracts? The corticobulbar tracts are responsible for conveying motor commands from the cerebral cortex to the cranial nerve nuclei in the brainstem. Their primary functions include voluntary control of facial muscles. They control the muscles of facial expression, allowing for movements like smiling, frowning, and other facial expressions. This includes both the upper and lower parts of the face. Control of muscles involved in speech and swallowing. They coordinate the movements of the tongue, lips, and pharynx, which are essential for speaking and swallowing. This involves muscles controlled by cranial nerves, such as the hypoglossal, trigeminal, facial, and vagus. Eye movements. They influence eye movements by sending commands to the oculomotor, trochlear, and abducens nerves. Jaw movements. They regulate movements of the jaw through the trigeminal nerve, which is responsible for chewing and other jaw actions. Question 5. At what levels do the spinal cord tracts decussate? The decussation, crossing over of spinal cord tracts occurs at different levels depending on the tract. Lateral corticospinal tract decussates, crosses over, at the level of the medulla oblongata in the lower part of the brainstem. Anterior corticospinal tract decussates at the level of the spinal cord where it synapses with lower motor neurons, generally near the segment where it will have its effect. Fasciculus cuneatus and fasciculus gracilis decussate at the level of the medulla oblongata, where they form the medial lemniscus before ascending to the thalamus. Lateral spinothalamic tract decussates at the level of the spinal cord near the entry point of the sensory fibers, often within a few segments of their entry. Anterior spinothalamic tract, similar to the lateral spinothalamic tract, decussates at the level of the spinal cord near the point of entry. Dorsal spinocerebellar tract does not decussate. It remains ipsilateral on the same side throughout its course. Ventral spinocerebellar tract decussates in the spinal cord and then crosses back to the ipsilateral side in the cerebellum. These decussations are crucial for the integration of sensory and motor information across different sides of the body and the brain. Question 6. What is the salient difference between cauda equina and conus medullaris syndrome? Cauda equina syndrome, CES, is a condition resulting from compression or damage to the cauda equina, a bundle of spinal nerves and nerve roots located below the conus medullaris. Conus medullaris syndrome, CMS, is a condition caused by damage to the conus medullaris, the tapered end of the spinal cord, which typically occurs at the L1-L2 level. Question 7. What is anterior cord syndrome? What would be the functional deficit? Anterior cord syndrome is a type of incomplete spinal cord injury that affects the anterior, front portion of the spinal cord. This condition typically results from injury or damage to the anterior two-thirds of the spinal cord, often due to trauma or vascular issues, such as an anterior spinal artery occlusion. Because the anterior portion of the spinal cord houses the corticospinal tracts, which are responsible for voluntary motor control, patients often experience loss of motor function below the level of the injury. This can lead to paralysis or weakness in the muscles of the arms and legs. The spinothalamic tract, which carries pain and temperature sensations, is also located in the anterior portion of the spinal cord. Therefore, individuals with anterior cord syndrome may lose the ability to feel pain and temperature below the level of the injury. The posterior columns of the spinal cord, responsible for proprioception, sense of body position, and vibration sense, are usually spared in anterior cord syndrome. As a result, these sensory modalities are often preserved, allowing individuals to maintain some awareness of body position and vibration, even if pain and temperature sensation are lost. In summary, anterior cord syndrome primarily affects motor function and pain temperature sensation, while proprioception and vibration sense typically remain intact. Question 8. What is posterior cord syndrome? What would be the functional deficit? Posterior cord syndrome is a type of incomplete spinal cord injury that affects the back, posterior portion of the spinal cord. This condition can result from conditions such as trauma, tumors, or other diseases that affect the posterior columns of the spinal cord. The posterior columns, dorsal columns, of the spinal cord are responsible for transmitting proprioceptive, sense of body position, and vibration sensations. Damage to these columns results in a loss of these sensory modalities below the level of the injury. The corticospinal tracts, which are involved in voluntary motor control, are not typically affected in posterior cord syndrome. As a result, motor function may be preserved, and individuals might retain their ability to move, although there may be some degree of motor impairment depending on the extent of the injury and any associated complications. The spinothalamic tracts, responsible for pain and temperature sensations, are usually unaffected. Therefore, individuals with posterior cord syndrome often retain their ability to sense pain and temperature. Overall, the primary challenge in posterior cord syndrome is the loss of proprioception and vibration sense, which can affect balance and coordination, while motor function and pain temperature sensation remain relatively intact. Question 9. What is central canal syndrome? What would be the functional deficit? Central canal syndrome, also known as syringomyelia or syringomyelic syndrome, involves the formation of a fluid-filled cavity, syrinx, within the central canal of the spinal cord. This condition can be caused by various factors, including congenital abnormalities, trauma, or tumors. The syrinx can affect the crossing fibers of the spinothalamic tract, leading to a cape-like loss of pain and temperature sensation over the upper back, shoulders, and arms. Sensation may be preserved in the lower body. Depending on the size and location of the syrinx, There can be varying degrees of muscle weakness or paralysis in the upper extremities, particularly in the hands and arms. This can result from damage to the anterior horn cells, lower motor neurons, or corticospinal tracts, upper motor neurons. In some cases, central canal syndrome can affect autonomic functions, leading to issues such as changes in blood pressure, sweating abnormalities, or problems with bowel and bladder control. If the syrinx affects the posterior columns or cerebellar pathways, it can result in difficulties with coordination and balance, leading to ataxia. The symptoms and severity can vary based on the size, location, and rate of progression of the syrinx. Early diagnosis and management are crucial to prevent further neurological damage. Question 10. What is Brown-Sequard syndrome? What would be the functional deficit? Brown-Sequard syndrome is a type of incomplete spinal cord injury characterized by a hemisection, damage to one side, of the spinal cord. It is named after the French neurologist Charles-Édouard Brown-Séquard, who first described the condition. The side of the body affected by the injury will experience weakness or paralysis. This is due to damage to the corticospinal tracts, which are responsible for voluntary motor control. The motor deficits occur on the same side of the body as the injury, ipsilateral side. The posterior columns, dorsal columns, carry proprioceptive and vibratory sensations. Damage to these tracts results in loss of these sensory modalities on the same side as the injury. The spinothalamic tracts, which carry pain and temperature sensations, cross over to the opposite side of the spinal cord shortly after entering the cord. Thus, damage to these tracts results in loss of pain and temperature sensations on the opposite side of the body, contralateral side, from the injury. In summary, Brown-Sequard syndrome leads to a characteristic pattern of sensory and motor deficits, weakness and loss of proprioception, vibration on the same side as the injury, and loss of pain and temperature sensation on the opposite side. This specific pattern helps in diagnosing the condition and localizing the spinal cord injury.